In my opinion, they get very limited training in musculoskeletal conditions. So for a primary care physician to see a patient with back pain, to me, is out of their scope of practice overall. I mean, they can handle the, major conditions and things like that, but that would be like us trying to treat somebody with a complex, endocrine problem or something like that. Physical therapists are the providers who should be the front door to the management of musculoskeletal conditions. And not that we can diagnose cancer or some of these other things, but we know the patients that belong in our clinic today and those that don't.
Okay, welcome to the Hands-On, Hands-Off podcast from the American Academy of Orthopedic Manual Physical Therapists. I'm Amy McDevitt, and today I decided to bring on my good friend and colleague, Paul Minkin. Paul has been a therapist for over 30 years. He's been in academics, and he's also been involved in entry-level education, residency education, fellowship education. And today I wanted to just have him chat a little bit about an article called The Worst Pain is an Unexplained Pain. And that was published in JOSPT just recently. But we've had some kind of off-screen conversations about this topic. And I just wanted to bring Paul on to talk a little bit more about it. So, Paul, welcome. And thank you for agreeing to come on the podcast today.
Well, thanks for having me, Amy. And you forgot to mention you're an author on that paper too. So
Yeah. Yes, that's right. So I'm an author, and then we also have Jeremy Lewis as the senior author on this paper. And what was kind of fun, Paul, if you don't mind me telling the story, is the three of us were chatting at the AAOMPT conference last year and just talking about things that we were passionate about and work that we're doing and research and that sort of thing. And we kind of just made a little bit of a pact or a decision to write a couple passion papers with each of us leading a paper about something that we were passionate about. And so this is kind of a fun result of a conversation that started at a conference. Paul, tell us a little bit more about why this is a passion paper for you.
Well, I have always respected Jeremy Lewis's work, and so he gave a pre-conference course at AAOMPT last year, which was outstanding. But he brought up this quote by Hilary Mantel that the worst pain is an unexplained pain, and that just really resonated with me. And how do we make sense of that to our patients? And that's always the challenge, whether they come in with imaging that shows this is going on, or the really tough one is the patient who has maybe symptoms and has x-rays and has an MRI and doesn't show anything, right? And so they're
Right.
like, what's going on now? And I see a lot of patients who have been to, chiropractors and physical therapists and physicians, and the physician tells them, it's a disc problem, and the chiropractor tells them they've got a vertebrae out of place. And PTs are as guilty as anybody else of labeling patients. Your SI is out of place, or your nominat's rotated, or things like that. So they've heard three different stories from three different providers, and they don't know where to go with that. And just trying to make sense of that for the patient that's sitting in front of you can be challenging. So,
Yeah.
and we'll get into talking about the ICF model and things like that. But, as physical therapists, we treat human beings. We don't treat pathology. So, shifting the focus away from trying to pinpoint the pain generator is a useless exercise for most of our patients.
Yeah, and you said something that resonates with me too. It's kind of both sides of this argument. So it's whether the patient has had imaging, and there's a whole plethora of things that were read by a radiologist. The patient is reading sometimes even before they have an opportunity to interact with the provider to get context. And it's the patient who doesn't have any findings on imaging that feels like something has gone horribly wrong because there's no evidence of anything that's problematic or explaining why they have certain symptoms. So I like that you called that out, because it can happen on kind of both sides of that argument. So my first question is, what are some of your experiences that kind of shaped your decision to write this viewpoint?
Well, over the years, I've had countless patients who come in with pain, but there's no clear structural cause overall. Maybe their imaging looks normal, but their suffering is real. So, what moved me to write this piece was talking to Jeremy, but also reflecting on those patients that have bounced between providers, each giving them a different diagnosis overall, and it leaves them just confused and not sure where to go forward, afraid to move, thinking their back or whatever is going to explode if they load it. So In practice, I see that the worst pain isn't the one we can see on an MRI. It's the one that we can't explain to the patient in terms that they understand. So really, my goal is to help patients make sense of their pain, even when we can't pinpoint an exact anatomical diagnosis.
Yeah. Yeah, I think that's true, and I think it's something that I see in my setting because I treat, a little bit of a different population working in a healthcare, system for a hospital, is that, trying to describe to patients some of these things are normal age-related changes, and they may or may not be pain provoking, and so I think that's another kinda layer to this conversation is, we shouldn't have an expectation that imaging looks normal in people that are over the age of 50 or 60 or 70.
Yeah, or
Um
even younger individuals. I treat a lot of college age students, and the research shows that, especially with a condition like back pain, the individuals who have never had back pain are going to have findings very commonly on imaging. So, saying that that's the cause of their pain is not valid.
Yeah, yeah. And so I love this this part of the argument comes early in the paper, and there's a quote here I'm going to read. It's receiving a diagnosis carries a personal significance for patients as it provides a framework for understanding their pain, validates their experience, and guides their recovery. So yet, the article says, the worst pain is an unexplained pain. So how do you balance the need for diagnostic clarity with the reality that some musculoskeletal conditions lack a clear structural cause?
Well, that's where I'm honest with patients, and I do talk about the research that looks at asymptomatic individuals with whatever their condition is, whether it's shoulder pain, back pain, hip pain, those kind of things. The prevalence of pathoanatomy in asymptomatic individuals is through the roof. So
Yeah.
just starting off, with that, and I tell them that it's very unlikely that I'll be able to exactly pinpoint what structure is causing your pain, but my job is to kind of listen to you as a human being and examine you and come up with all of the contributing factors that may be playing a role in why you have pain, whether that's limited mobility, limited flexibility, limited strength, lack of sleep, poor nutrition, high stress, those kind of things. So just reinforcing to the patient that human beings are complex organisms, that
Yeah.
there are multiple factors that contribute to a pain experience. My job is to tease out which ones can we identify, which ones can we modify, and moving forward from that standpoint.
Yeah, I don't know if the profession has evolved, Paul, or if we've evolved, but I feel like I also see things in a different lens, and I used to just think in terms of, okay, they have low back pain and this is the multimodal approach and these are the interventions, and somehow now there's and maybe it's because there's been more work in the area, but I'm thinking and looking at so many different things, including what you just spoke to, which is lifestyle factors, but also what's going on in their lives and where they live and how they function and what kind of transportation they access and spirituality, and there's all these other dynamics that play in that I never really appreciated before. So I don't know if we've changed or if the profession has changed and really decided to put a spotlight on some of these other more person-centered factors that really matter.
Yeah, I think it's both. I think hopefully we continue to evolve and start to realize again that we're treating human beings. We're not treating pathology.
Yeah.
Especially as physical therapists and that kind of thing. And then one other point I wanted to comment on. I also teach in fellowship, and I had a fellow say once, if a patient comes into me and brings their MRI, I tell them I don't even want to see it. And for me, that is like slapping the patient in the face. They've
Mhm.
spent this time, this money to get this image, and you won't even look at it. Now, we've talked about how pathoanatomy is prevalent in asymptomatic individuals, but you need to validate that patient's
Yeah.
experience, what they've been through, and that kind of thing. So I will take the time to pull it up. Let's look at this and go through it, and then I will, look at what they find on the imaging, and I will tell the patient my job is to see if what I find in my clinical exam correlates with what we see on the imaging. If it does, great, we'll move forward. If it doesn't, then there are some other things that we can treat. And again, it is common for individuals to have pathoanatomy on imaging that does not correlate
Mhm.
to symptoms.
Yeah, and I find myself having that conversation actually quite a bit with my patients because most of them present to PT with imaging in hand because we're in a hospital-based system, and that's just how that system works. So, tell us a little bit about how the ICF model and maybe using language surrounding a functional diagnosis might help some of this situation with our patients.
Well, again, we're trying to identify things that we can treat. We're not going to go in and fix somebody's disc or if they've got a torn labrum in their shoulder or something like that. So, I'm going to be identifying impairments to movement. You look at the mission statement for the APTA, optimizing human movement and that type of thing. So, my exam is really focused on barriers to the tissue that whatever tissue it is that they've injured, making a complete recovery. So that includes physical factors like strength, flexibility, mobility, those kind of things, but also those other lifestyle things that we talk about. So I tell my patients at the end of the exam, look, you have back pain. I don't know exactly what the structure is, but these are the key impairments that I have identified that I think are barriers to you getting back to doing what you need to do. And we're going to focus on treating those because the research would suggest if we improve those things, it's likely that you'll feel better.
Yeah. And we speak to in the article a little bit about using words like things are irritated or sensitive, or I find myself with patients using, you're not really, you're sensitive to load right now. And those, those resonate with patients. Like your nerves are irritated, things like that, instead of using, more of that pathoanatomic language that we know can in some patients be harmful. But I do feel like patients understand it when we break it down in that way. Have you ever had trouble kind of implementing some of that language and talking about, mobility impairments or movement coordination or things like that with patients?
Yeah, I mean that's always a challenge. I mean, a lot of patients come in with the thought that pain equals harm. Every time I
Yeah.
feel pain, causing damage to the tissue overall, and so that's the first thing we need to kind of straighten out. And I'm a big advocate of pain science education, but I think a lot of it has gone way overboard. That we don't need to get that detailed with our patients overall. Look, there's these things that are contributing to the symptoms that you're having, and like you said, your tissue just got overloaded. If you are a sedentary individual and you help a person move and you expose your back to loads it hasn't seen in 10 years, we would expect that you would be a little bit sore. And it does all come down to load and building the tissue's biologic capacity to tolerate load. And if you explain it in that terms to patients, in those terms to patients, it tends to resonate with them.
Yeah. So, do you mind if we go off script for a minute and I play the patient with my imaging in hand and you kind of reframe the conversation?
Sure.
All
Yeah.
right. So, I'm gonna for a moment pretend that I'm much younger. I'm a 35-year-old female. But Paul, I've been having all of this pain going down my right leg, and I had an MRI because my doctor thought that would be the next step. And I have disc herniations. So I have disc herniations that they said L3 and 4, L4, 5, both on the right and the left side. And I've got some decreased disc height, is what the MRI report had said. And so, what are we going to do about this? I don't know that I think physical therapy is going to work because we talked about injections.
Yeah. So first of all, I want to validate that your pain is real, and I apologize that you have to go through that, and I understand that may be difficult for you to be going through that. Again, with my exam, I'm going to be trying to correlate what we see on imaging with some of the symptoms that you have, and they may correlate with, what we see on the imaging, and they may not. But we do have some good treatments that we know that can decrease the load in the region here and optimize the mobility of the tissues around there. But really, our goal is to create the optimal environment for your back to recover from whatever is going on in that region. So there's likely, with the imaging findings that we're seeing, some inflammation, some overload in through that area. And if we can get that calmed down, then the tissue can heal. As soon as that starts to heal, your symptoms will improve. There may be flares as we kind of go through things. Obviously, if the imaging is showing all of those things overall that are going on, we want to be respectful of that as we're progressing through. But the goal is to get you back to doing the things that you want to do, and not laying around. We know that bed rest and things like that just tend to make these symptoms worse on multiple levels, both from a healing level and a psychological level. So, I don't want to dismiss what we see on the imaging, but there's plenty of people out there who have really uh, terrible looking backs on imaging who have no pain. So there's no reason why you can't get back to doing what you need to be able to do.
Yeah. That was pretty good, Paul. I'll give it a, what, 9 out of 10? Maybe a 10 out of a 10 if you inserted a little teach back in there or something, but no, I'm joking, that was great. I think you covered so many bases. You talked about, maybe decreasing some catastrophizing if that's present because, you kind of normalized a little bit of the imaging, but then you also talked about contribution of lifestyle factors and other things that we'd be doing together, um, in physical therapy in order to mitigate some of that pain. But I think it's great to just give people an opportunity to hear what a conversation might be like that you would have with a patient. You started to talk a little bit about lifestyle, and so the article did cover some and highlight some of these lifestyle factors like sleep and stress and nutrition. And how do you kind of integrate those into your treatment plan, or maybe you titrate them in over time without overwhelming the patient or maybe stepping out of our scope of practice?
Yeah, so that's a great question. One of the things I'll use, especially with somebody that's had symptoms for a while going on, is I'll have them watch that YouTube video, Explain Pain in 5 Minutes, because it does such a nice job of going through all of the different lifestyle things that may be contributing to symptoms such as sleep and stress and nutrition and activity levels and that type of thing. So I like to really frame lifestyle as part of recovery. It's not an add-on. And I
Yeah.
explain to patients that pain is like a dimmer switch. So things like movement, sleep, stress all have the ability to either turn that dimmer down or turn it up. And then I try to pick, after the patients watch that 5 minute video, I say, did anything resonate with you there on your sleep, on your
Mhm.
diet, your exercise levels, your stress levels, things like that? Did anything resonate with you on that front? And they'll always come up with one or, yeah, I should get some more sleep, or I should drink more water, or things like that. And then I'll pick one small achievable change at a time. So maybe, let's increase your activity. Let's try and have you go for a 10-minute walk every day. Or let's come up with a consistent bedtime. Why don't you start going to bed at the same time every night so you get a consistent amount of sleep so your tissues can heal. So I try not to become a nutritionist or a psychologist. I just try to help them see how these habits can influence healing, and collaborate with them on coming up with some strategies that may help them.
Yeah, and I think based on my experience, even incremental change is change. So even if we can help them implement a little bit of extra sleep or a 15-minute walk, and I usually say to patients outside always, unless it's not safe or the weather is not in favor, it's so good for you to do that. But there is a lot of power in it being incremental, and I don't think we're necessarily outside of our scope in making those recommendations.
Yeah, and it can be overwhelming for patients if you throw it all at them at
Right.
once. I need you to eat better, and I need you to sleep better, and I need you to drink more water, and I need you to decrease your stress levels, and I want you to do some mindfulness kind of things. The patients are like, whoa, whoa, whoa. This is physical therapy, isn't it? So,
Yeah, yeah. Um, you talked about like the importance in the article of language, and we did talk about this already a bit. But what are some common phrases or metaphors that you have found helpful, or maybe even harmful in communicating things to patients?
well, and we've all heard these, but I see college age students who are told by their healthcare provider, you have the spine of a 70-year-old, or you're
Mhm.
it's out of alignment, or you need to be careful. You could make this worse, those kind of
Yeah,
things. Really educating the patients that really, if we're talking about back pain, your back is strong and it can tolerate a lot of load. It's not going to explode if you bend forward, which a lot of patients truly believe that if they bend forward and try and touch their toes, something terrible is going to happen. And then also, the pain science stuff. Pain does not equal harm. If you
yeah,
can get that into patient's head. Yeah, you
yeah,
you hurt your back. You helped somebody move last weekend, and your back is really sore, and it's probably going to be sore for a period of time overall. But pain does not mean you're causing any damage to the tissues overall. And then really getting the patients to think about their body as a complex system that requires, not just strength and mobility, but all those other lifestyle factors, appropriate sleep and decreased stress levels and those kind of things.
Yeah. And I have another kind of separate question. I remember we talked about this with Jeremy when the three of us were just kind of having a conversation about some of this. But at least where I'm working in outpatient in a hospital system, imaging is a huge barrier, and I spend a lot of time undoing. I have a patient that comes with imaging, and then we have to talk about, thinking about the imaging in a slightly different way. And it's not catastrophic, and your body is strong. And to your point, your lumbar spine is well supported ligamentously and by all these muscles. And maybe you're just reacting, the tissues are reacting to some load. But Jeremy was describing, he didn't quite have the same problem because they don't utilize imaging as readily or as often as we do in the United States. Where do you see how are we ever going to kind of get around this culture? And maybe it's too big of a question for us to even think about, but it's really a barrier, in my opinion, to recovery. What do you think the answer is, at least in the United States and in our health system, in terms of our utilization of imaging, or overutilization, I should say?
Yeah, well, it's got to be a systemic change overall. And if we just followed the guidelines, I mean, the guidelines are very clear. If you have a new onset of back pain with no red flags, imaging is not indicated. Don't
Yeah.
even go there. But unfortunately, like you said, when you were talking about Jason, he feels like he has to order the imaging or whatever. It's kind of part of the script that you go through. But really changing that. If you read the guidelines, they are very clear. And if we just followed that. On the radiology front, it's interesting. Where I practice up in Boulder, a lot of the radiologists are starting to put little blurbs at the bottom, like normal age. These may be normal age-related changes, or patients who are from 30 to 40. It's common to see this or that. Just to put that in on the bottom, so that the patients can see that some of these findings are normal in people who don't have symptoms overall. But the setting I work in, we about 70% of the patients we see are direct access, so they come in and see us first. Man, seeing somebody with 2 days of back pain who has not seen another provider is, life changing as a physical therapist, compared to the patient who has seen 10 providers and had pain for 5 years and had all the imaging and things like that. Those are so much harder patients to treat overall, because they've got all of this information in their head that is just change. We've done a lot on expectations. Their
Yeah.
expectation is rude, right? Their back is broken.
Yeah. I envy you, Paul. I haven't seen a patient with acute low back pain in over 10 years. Unfortunately, we don't have direct access in our hospital system, which is unfortunate because we're in a state that allows direct access. But I'm not gonna stir up that hornet's nest at the moment. But
Yeah.
it's unfortunate because I believe, and this too, the trajectory can be so different when you see someone just a couple days out of an injury or a new onset of pain versus someone that I usually can't see for 8 to 10 weeks. And by then they've
Yeah.
already had imaging, and a whole plethora of other things have happened, in that time, which is just, again, it's just unfortunate.
I taught a course this weekend and had a great discussion with some of the people there, and the we kind of talked about primary care physicians' role in treating conditions like back pain. And in my opinion, and you've taught the medical students at the University of Colorado as well, they get very limited training in
Yeah.
musculoskeletal conditions. So for a primary care physician to see a patient with back pain, to me, is out of their scope of practice overall. I mean, they can handle the major conditions and things like that, but that would be like us trying to treat somebody with a complex endocrine problem, or something like that. The physical therapists, the providers who should be the front door to the management of musculoskeletal conditions. And not that we can diagnose cancer or some of these other
Yeah.
complex things, but we know the patients that belong in our clinic today and those that don't, and we refer appropriately. I mean, we published a report on over 16,000 patients seeing direct access. We didn't miss a single fracture or tumor, or that type of thing. So, again, we should be the ones seeing them. And if we do, the trajectory is completely different.
Yeah. Yeah, I agree with that. I was just yesterday, I was talking to Steven Spoonmore, who we both did research with many moons ago, and he has worked for a number of years up in Alaska with some of the indigenous populations. And we were talking about this really cool, primary care model that they were trying to get off the ground, where patients are being triaged by this team, including primary care and sometimes behavioral health and PT as a part of that, in order to kind of have this team-based approach to determining the best path for the patients. And I think is really cool, and I think it's kind of the ideal. So hopefully we can continue to work towards those models. um
Yeah. And
yeah.
Rebecca Griffith in the emergency room, getting
Yep.
physical therapy in the emergency department. That is life changing overall for everybody involved, even the healthcare providers. So another
Yeah,
topic.
absolutely. And she's done some great work, I believe, in really messaging that and how important that is at both a national and international level, which hopefully is another, kind of agent for change. So in terms of education, I mean, we're both, entry level educators, but on top of it, you educate in some residency and fellowship. What from that lens, what do you think needs to change in terms of how we educate students? Or learners, I should say, to better be prepared to kind of have this person-centered, non-pathoanatomical approach. And how do you still talk about pathoanatomy without it translating to the speak that we use with the patients? Because we're advocating in this article, in this viewpoint, to really talk about more of a functional diagnosis.
Yeah, I mean, it's kind of the nature of the beast that we need to teach our students how to do all these exam things, and we have all these special tests that purportedly identify structural pathology and things like that. But I'm really trying to move my students away from that. I'll teach them those tests, but I also teach them how to interpret the findings, meaning that you can't rule in most conditions that we're seeing, and really emphasizing that teaching them how to connect with people and how to improve the therapeutic alliance and treat the human being that's sitting in front of you. This is not a knee, this is not a shoulder, this is not a back. This is a human being that has complex things going on. So part of it is just it's habit. It's what's been done before and that kind of thing.
Yeah.
So we really need to shift the educational model from teaching our patients to look for something that's broken or something to fix, and steering more towards that ICF model to think in terms of function and how impairments affect a human being's daily life, not just what structures are involved. So I try to present a balanced approach with it, but unfortunately, they need to learn some of these special tests for the board exams and things like
Yeah.
that.
Right.
But I really do look at individuals now from that ICF model. They have low back pain with what's the underlying impairment that's most likely to give us the biggest bang for our buck from the intervention standpoint, and then really teaching them about the therapeutic alliance and taking time to get to know the individual. I've said over and over again to my students, your interaction may outweigh your intervention. So,
Yeah. Yeah. It is tricky because we have to kind of teach both things, and then at the same time somehow cohesively deliver a message that we don't want to be over emphasizing pathoanatomic terms with patients. I was just teaching in our hybrid immersion University of Colorado yesterday, and we were working on teaching students shoulder content. And one of the ways I felt like I could kind of try to couch this together is we were talking about shoulder pain with movement coordination deficits, but then we were talking about what pathologies might kind of nest underneath that. But still, because we don't have confidence that we know for sure that someone has multi-directional instability, or that they have a labral issue, it's still just a hypothesis under this broader category of movement coordination. And so I was trying to figure out a way to kind of house pathoanatomy under each of these, but being very explicit with the students that we don't have confirmation, all the time, that this is exactly what we're dealing with, and it can be harmful to describe pathoanatomy to the patient in the absence of clarity. Because to your point earlier, even with imaging, we don't have 100% clarity that that's the pathoanatomy that's kind of driving the symptoms. So
yeah, and I've used that engineering that meme or whatever, the engineering flow chart where does it move? Yes. Should it? No. Then, then what are we going to do? We're going to stabilize it. We're going to put some duct tape on it or that
Yeah.
kind of thing. Try and hold it down a little bit or keep it from moving too much. Or does it move? No. Should it? Yes. Then that's WD-40. Squirt some WD-40 on it so it moves a little bit better. So applying some manual therapy. So when I use those same kind of descriptions to patients, you're a little stiff through here. You're not moving
Yeah.
like you should. And if we can improve the mobility here, then it's likely that it will decrease the amount of compensation you need to do at the level above. Or, if you're moving too much, we need to just, improve your body's ability to stabilize that level and, keep it from getting irritated by moving beyond its normal physiologic motion.
Yeah, and I agree, and I think that actually makes sense to people. Somehow we just get tempted to kind of fall in the trap of pathoanatomy, but that's not always the most productive place to go. But I agree. I think that language makes a ton of sense to people.
Yeah.
Um, so as we kind of close up, what are some things that you're currently working on, or what other passion projects do you have? Or are you working on any research right now? What's blowing your hair back at the moment, Paul? Well, I guess you don't have that much, so.
Yeah, don't have that issue. I'm really moving into, looking at burnout and mindfulness and things like that. We're working on a project where we're looking at dry needling. We just published a case report on a patient that I caused a pneumothorax on, which,
Mhm.
I think as a profession, we need to be honest and say these things do happen. And the prevalence is probably much higher than we think it is overall. So, we're going to explore that and kind of survey emergency room physicians and kind of see how often do they see patients who have developed a pneumothorax due to potentially needling or those kind of things. But we're also, Josh Cleland and Megan Donaldson and I are working on looking at burnout in academic faculty overall,
Mm.
because there's a lot of evidence in medical literature, but as far as allied health, physical therapy, speech, occupational therapy, we don't really have a good handle on the level of burnout in academia overall, because I've been through it. Josh, my best friend, has been through it,
Mhm.
and it's definitely challenging. So number one, what's the prevalence of burnout in academic faculty, and then ultimately, how can we improve that or decrease the likelihood of that happening? So those are a couple of the big things that I'm working on, but I have my finger in a lot of different things, educational competencies and things like that, but plenty to keep me busy.
Yeah,
So
great. Well, I look forward to catching up at the conference, which is coming up in a couple weeks, and then also seeing the fruits of your labor in terms of some of this burnout work, which is very different from, I think, medicine. And so I love that you're calling that out and doing a little bit more work to explore maybe what some of the differences are and how we can mitigate it. Because it's hard work being in academia, lots of high expectations, and so I look forward to hearing a
yeah.
little bit more about that.
Yeah, one more quote from Julie Whitman. I remember she told me, in academia, once you get on the treadmill, you can never stop running. So
Yeah.
that's how it feels sometimes. So
I that resonates. All
yeah.
right, Paul. Well, it was a great conversation, and thanks so much for the conversation about some of the work that you're putting out there. And we shall see you again when another brilliant paper comes out. We'll bring you on and unpack it together.
All right. Thanks so much, Amy.
All right. Thanks.
Thanks for listening to Hands On, Hands Off, the official podcast of AAOMPT. Subscribe now so you never miss an episode, and connect with us at aompt.org or at AAOMPT on social. Opinions are those of the guests and not official AAOMPT policy. See you next time.